Hi friends, today I will discuss about precision antimicrobial selection in the ICU when we balance the efficacy as well as maintain the principles of antimicrobial stewardship. We will discuss a few clinical cases and we will see what all options we have when we select antibiotics for our ICU patients. So let's start. So as we all know, antibiotic resistance is a major health problem and it will likely become one of the leading causes of death worldwide. And ICUs are the places where antibiotics are widely prescribed and MDR pathogens are frequently encountered. And here we are going to look at the key opportunities to reduce antibiotic consumption in ICU setting through the evidence-based antimicrobial stewardship programs. So why stewardship matters? So as we can see, 33,000 annual deaths in Europe because of MDR infections, 1.2 million global deaths, and 33% prescriptions where there was unnecessary use of antibiotics because of lack of stewardship. So the ICUs must lead effective antimicrobial stewardship program to counter this challenge. Now, when to start antibiotics? So, of course, in septic shock, we all know immediate administration of antibiotics, broad spectrum antibiotics within the first hour itself, because delaying treatment leads to increase in the mortality. However, when there is suspected infection without shock, we should consider withholding antibiotics until evidence of infection is clear. This way, we can reduce 25% of patients who would receive unnecessary antibiotics. And at the same time, we should also try and identify the source of infection, take microbiological sample before starting antibiotics, and use invasive examination when needed. Let's discuss two clinical cases. The first case is a 25-year-old woman, 8 days post LSCS, who developed fever and acute abdomen 6 days after the cesarean section. Her CT scan confirmed perforation peritonitis. She had no other comorbidities. The second case is an elderly lady, 70-year-old, hypertensive, presented with history of abdominal pain, fever, and anorexia, and CT abdomen showed perforation peritonitis for her also. She has no history of recent hospitalization or antibiotic use. Both the patient presented with shock, could be septic, could be hypovolemic. So the question arises, what antibiotic empirically should we start? So just give it a thought in your mind, pause for a moment and think what would you start in this case, and then let's move forward. So first we need to know, when we choose antibiotic, what are the common organisms in perforation peritonitis that we are targeting. So let's see one by one. So gram-negative bacilli, including E. coli, Klebsiella, Pseudomonas, and Enterobacter species for community-acquired cases. Gram-positive cocci, including Enterococci, Streptococcus species, which are part of polymicrobial infections. Anaerobes like Bacteroides fragilis and Clostridium species, typically in lower GI perforations. Resistant stains, including ESBL producing organisms and carbapenem resistant Enterobacteriaceae in healthcare associated cases. And fungal pathogens, which include mainly Candida species, especially in immunocompromised patients and those who have received prolonged antibiotic exposure. So these are the common causes of perforation peritonitis. Now, what are the risk factors for MDR infections in patients who present with peritonitis? So let us see. Prior antimicrobial therapy within 90 days, like our case 1 who was post LSCS, healthcare exposure, prolonged hospitalization more than 48 hours, or recent ICU admission, they increase the risk of MDROs. That is also relevant to the case 1. Invasive procedures like recent abdominal surgery, as seen in case 1, or indwelling catheters, Immunocompromised state. Advanced stage is not a very strong uh, condition when we can say she is immunocompromised, but that is a risk factor. Diabetes, malnutrition during prolonged illness, or immunosuppressive treatment. And geographic conditions, local resistance patterns, these things should be also taken into account. Now, also, what are the risk factors for MRSA infections? So, healthcare associated factors are going to be the same: the recent respiratory system infection, mechanical ventilation, chronic respiratory diseases, recent antimicrobial exposure, as we discussed in the previous slide, skin and soft tissue factors, including open wounds, dermatological conditions, burns, and shared personal items, and also immunological factors and geographic and community factors. Now, in my hospital, probably what we would have done for these patients. So, there are certain options that, depending on who saw the patient, different people would think differently and start different things. So, let's see one by one. So, we would have considered starting ceftriaxone, piperacillin tazobactam, meropenem plus clindamycin, metronidazole, and probably someone would have also thought about antifungals. So we will dissect each of these and see what organisms they cover and when their use is appropriate. So let's start with ceftriaxone as empirical cover. So as we all know, this is a third generation cephalosporin. It is generally reserved for only community acquired infections. It covers most Enterobacteriaceae who do not produce ESBL, of course, and limited gram positive infections like streptococcus, but it is ineffective against enterococcus and MRSA. And also, in terms of anaerobic coverage, it is not effective against bacteroids, and if you want to cover bacteroids, you need to add something else. So it is best applied as a first line therapy for community acquired pneumonia and meningitis when the resistant risk factors are not there. Coming to piperacillin tazobactam for empirical coverage. So this is a broader spectrum compared to ceftriaxone. It covers Pseudomonas, Enterobacteriaceae, some anaerobes, and many ESBL producers also at high doses. So clinically, if we see, it is a first line for healthcare associated pneumonia, intra-abdominal infections, febrile neutropenia, and complicated UTIs. Although it is a broader spectrum, it is still insufficient against MRSA, Acinetobacter, and resistant entococci. So we need to consider local resistance patterns. Like for example, in our setup, we find resistance more often than not, and we generally do not consider piperacillin tazobactam when we are thinking about resistant organisms. Next is meropenem plus clindamycin. It is a very popular choice in our hospital. And let's see what it covers. So meropenem would cover gram-negative organisms including Pseudomonas, ESBL, and Enterobacteriaceae in bacteremia and systemic infections. Clindamycin will provide anaerobic coverage for aspiration pneumonia, lung abscess, and necrotizing soft tissue infections. And it will also have some methicillin sensitive staph aureus activity. As a combined combination, they will cover broad spectrum including intra-abdominal, complicated skin, and polymicrobial infections. However, the cover is still inadequate for MRSA, VRE, and resistant enterococci in endocarditis and line-associated infections. So, as a combination, meropenem plus clindamycin will treat most polymicrobial infections but lacks coverage for resistant gram positives. So, rather, instead of clindamycin, if we want to give better gram positive coverage, vancomycin or linezolid or teicoplanin would be a good choice for suspected MRSA or endocarditis or catheter related infections. Now, which antibiotic covers anaerobes? So, from beta lactam group, piperacillin tazobactam is having some anaerobic cover. Carbapenems like meropenem can cover even resistant strains. And amoxiclav also can cover mild to moderate cases. Lincosamides, that is clindamycin, is also an option for oral anaerobes and aspiration pneumonia. It has got good bone penetration for osteomyelitis, and however, there is rising resistance in bacterioid species. Nitroimidazoles, that is metronidazole, is a gold standard for anaerobic coverage. It has excellent penetration in abscesses, and we add metronidazole when peritonitis or bowel perforation is suspected. And amongst others, tigecycline for polymicrobial infections, chloramphenicol, and moxifloxacin. These are other options. So when we actually add metronidazole, so we have when we are trying to cover for anaerobes like abdominal sores, peritonitis, bowel perforation, intra-abdominal abscesses, necrotizing infections for soft tissues with gas or necrosis, and aspiration events. So in these situations, when we are giving insufficient coverage for anaerobes, we should add metronidazole. So simply put, when we are giving something below meropenem, so in our examples, it could be ceftriaxone or piperacillin tazobactam, then it makes sense to add metronidazole. If you are giving meropenem or above, you do not need to add metronidazole separately. Now about antifungals. So there are two options generally, echinocandins and voriconazole. So let's see how they perform. So if you are suspecting candidemia, echinocandins are first choice. They have minimal drug interactions, but they have poor CNS penetration, so not effective in Cryptococcus. For voriconazole, it is drug of choice for aspergillosis. It has excellent CNS penetration, however, it has multiple cytochrome P450 interactions, and it covers some of the resistant Candida species as well. So in terms of selection, if we are suspecting Candida, which is more likely in bloodstream infections and peritonitis, we should consider echinocandins for a sick patient like ours. And if we are suspecting aspergillus, which is more commonly seen in the lung infections, we should consider voriconazole. So let's see what are the empirical therapies for perforation peritonitis. So first line therapy would be at least a piperacillin tazobactam for broad spectrum coverage, including Pseudomonas, and we can add metronidazole here. As an alternative, we can give ceftriaxone plus metronidazole for community acquired cases without risk factors of resistance. However, for both our patients who presented with shock and who had some or other risk factor, probably we would start meropenem plus vancomycin or teicoplanin because we want to cover suspected ESBLs or MRSAs. Antifungal like caspofungin or anidulafungin needs to be covered if we have an immunosuppressed patient with a prolonged hospitalization and prolonged antibiotic usage. Duration is typically 5 to 7 days post source control, and we have to de-escalate based on the culture results within 48 to 72 hours. Also, at the time of starting, we have to consider local resistance patterns. So if there is a high resistance of carbapenems also, probably we would add something higher than that like a tigecycline or polymyxin, depending on the presentation. Now, how do we limit empirical broad spectrum antibiotics using the antimicrobial stewardship principles? So first we need to assess risk factors like we assessed for MDR gram negatives and MRSAs. We should consider local epidemiology and resistance patterns in our ICU. We should try and restrict carbapenems as much as possible. Even less than 3 days of carbapenem use increases the likelihood of colonization with carbapenem resistance pathogens. So we have to try and limit the carbapenems and try and do rapid test which can quickly give us answers whether there is an ESBL or carbapenems producing organism, and we may escalate or de-escalate upon the receipt of the result. Also, we should avoid unnecessary anti-MRSA antibiotics. So in one of the studies for community acquired pneumonia, 38% patients received vancomycin, but only 4.6% had MRSA. An empirical MRSA cover will increase mortality, can cause renal failure, Clostridium difficile infection, and secondary infections. So we can do a nasal screening by PCR, and if it is negative, there is very high negative predictive value for community as well as hospital acquired infections. And case by case, we should decide whether to give MRSA cover rather than giving an empirical coverage. Now let's discuss antimicrobial stewardship techniques for critically ill patients with pneumonia. So these are the common organisms. So typical bacteria include Strep pneumoniae and H. influenzae, which predominates in all groups presenting with community acquired pneumonia. Atypical bacteria include Mycoplasma pneumoniae and Chlamydia pneumoniae, which present with young adults and in monsoon seasons. Gram-negative infections like Klebsiella and Pseudomonas are common with diabetics, COPD, and alcoholics. Resistant strains of MDR, Pseudomonas, and ESBL Klebsiella are now rising in urban areas with antibiotic misuse. And tuberculosis is endemic in our area, so it is always a consideration. Let us discuss about procalcitonin as a diagnostic tool. We all know that procalcitonin is produced by C cells from thyroid gland, and it has diagnostic limitation in terms of diagnosing the presence of infection. However, there are many studies which have showed that procalcitonin has good potential for discontinuing the antibiotic. Please note that the word is discontinuation and not de-escalation. To de-escalate, which means to narrow the spectrum, we need to actually have culture and susceptibility results. So let us look at how procalcitonin works. It starts rising within 3 to 4 hours after infections, peaking at 24 hours, and it has a half-life of 24 to 48 hours. It is falsely elevated with burns, trauma, surgery, and rarely in fungal infections. And in renal dysfunction, the baseline procalcitonin is elevated. So the interpretation becomes a little tricky. However, there are various studies and meta-analysis to show that use of procalcitonin to discontinue antibiotic has actually resulted in reduction in duration of antibiotic therapy. Now let us discuss the empirical therapy for VAP or HAP. So we all know for the first 5 days generally the organism is from the community itself. So we can use ceftriaxone plus azithromycin. Late onset VAP more than 5 days after intubation or hospitalization, we use piperacillin tazobactam or meropenem plus amikacin. When there is MRSA risk factor, we add linezolid or vancomycin, and we de-escalate within 48 to 72 hours based on the cultures and clinical response. Let's discuss about rapid respiratory panels. So these panels can identify pathogens very quickly versus 48 to 96 hours of traditional cultures. They detect organisms that are difficult to isolate or present in small quantities even after antibiotic administration. So the benefits include faster results compared to cultures, higher detection, so 90 to 95% sensitivity for most bacterial targets in BAL as well as sputum samples, and it leads to improved stewardship in the form of change in therapy in 77% of the pneumonia cases and de-escalation in nearly half of the patients. However, there are certain limitations of rapid respiratory panels which include false positive. So these tests may detect nucleic acids from dead pathogens and lead to overtreatment. They give us incomplete information, so still we lack the full susceptibility data to choose or de-escalate antibiotics. So we still need cultures, and these tests are expensive even for the USA. So that is something which we need to consider. Now let us discuss about monotherapy and combination therapy. So when we start empirical therapy, we may consider combination therapy, especially for patients who present with shock. So we can cover potential pathogens. However, when we are switching to definitive therapy, we should consider switching to monotherapy by day 2 or 3 with culture results, and this includes even for non-fermenting organisms like Pseudomonas. Also, combination therapy has to be considered only when there are difficult to treat pathogens like carbapenems producing Enterobacteriaceae. Then we should consider combination therapy. Otherwise, we are again moving towards monotherapy. Now about de-escalation. So when we work up, we gather the clinical information and other results. If we conclude that there is no infection, we should stop the antibiotic rather than carrying on. If we get culture sensitivity reports, we should narrow the spectrum of the antibiotics and try and use the narrowest spectrum effective antibiotic. When we have multiple options to choose from, for example, for ESBL, we have piperacillin tazobactam, we have cefoperazone sulbactam, and carbapenem as well. Then we should try and spare carbapenem and choose a BL-BLI combination as much as possible. So we should always try and focus on shortening the duration of antibiotic treatment. If we prolong the use of antibiotics, there will be more side effects. Shorter courses work as equally as longer courses. 7 days therapy is generally considered sufficient for most ICU patients, and we can use biomarkers like procalcitonin, which guides our therapy and reduce the days of antibiotics. These are the recommended days of treatment. So you can see uncomplicated bloodstream infection, uncomplicated catheter-related infection, community-acquired pneumonia, HAP, VAP, intra-abdominal infections, and severe community-acquired UTI. Generally, the duration is 7-8 days. We should be careful when we are treating complicated bloodstream infections or CRBSIs, and we are treating Candida and Staph aureus. Then we should consider longer duration of antibiotics. Also, when we are considering complicated male UTIs, we should consider prolonged use of antibiotics for up to 2 weeks. Now, if we think about the effect of stewardship on overall outcomes, there are better outcomes, improved survival of patients, less resistance, fewer MDR bacteria noted, fewer side effects including a reduced rate of Clostridium difficile infections, and of course there is lower cost because of lesser use of antibiotic, lesser days spent in the ICU and in the hospital. So this program is very useful and effective, and we should apply the principles of stewardship whenever possible, as much as possible. The stewardship programs can be implemented in a restrictive manner or incentive manner. So restrictive means we restrict the formulary, we need pre-authorization by an expert when we want to use certain reserve antibiotics. Generally, these kind of restrictive practices are not very effective. The other way is to use incentive based. So we continue to audit the usage, give feedback to the users about use of antibiotics and the prevalent resistance, and give education to the antimicrobial prescribers. Also, the organization can have a multidisciplinary approach and try and coordinate with different departments and teams to streamline the use of reserved antibiotics. So what are the key takeaways for ICU physicians? First is always thoughtful initiation of antibiotics. Refrain from using antibiotics immediately if we have some doubt and patient is not in shock. Try and identify the source and take blood samples first. Target your antibiotics to narrower spectrum as soon as you get culture results. Switch to monotherapy as much as possible, and whenever the culture results are available. And finally, shorten the duration of therapy. Use 7 days course for most infections and consider procalcitonin as a guide to stop antibiotics and reduce your treatment duration. I hope you have liked this video and found it useful. For more such contents, do check out my channel for other videos. Please share this video with your friends and colleagues, and please subscribe to my channel. Thank you and have a good day.